topic is going to be navigating neuro-op nightmares and nonsense. I am no longer in academia. I am a practitioner in a medical surgical practice called USI Center for Sight in Sarasota and Venice, Florida. My office is in Venice, and I do the neuro-op at that practice. When I was interviewed, the head ophthalmologist said, "Look, we're POAG, AMD, and cataracts are our bread and butter. We're never going to hire a neuro-ophthalmologist. You can do that for us." And I've been doing that. Now, these are my disclosures. Greg and
Hey,
I both.
Joe, before you go on to that, I
Yeah.
think the audience needs also know, and I can do that for you. As you mentioned, you were at Nova for 28 years. You're at Center for Sight in Sarasota and Venice doing the glaucoma and neuro-op. But I think it is also worth noting that you are a founder and former chair for tonight's, at least for tonight's webinar, chair of the Neuro-ophthalmic Disorders in Optometry Special Interest Group for the American Academy of Optometry. I think that's definitely worth pointing out, as long as a founding member of the Optometric Glaucoma Society, the Optometric Retina Society. And I think it's also important to point out that in 2023, you were ranked #1 as optometrist in the US Newsweek ratings. So, with tonight, I thought it was very important to point out that neuro-ophthalmic disorder special interest group at the Academy. So with that said, why don't you take the floor and do those disclosures? But I wanted to highlight those achievements.
Well, thank you, Greg. Everything's been mitigated. I'm on the Speakers Bureau for Bausch and Lomb, but there's no products in neuro-ophthalmology, it seems like. But I do have a couple other disclosures. I work in a large medical surgical practice. I'm not in an academic referral center. I book 25 to 30 patients a day, primary care, glaucoma, corneal disease, contact lenses, emergencies, and neuro-op. And I function pretty much as everybody else does here today. I don't have 2 hours to do a neuro-op evaluation. Now, you see the little iPhone there or the cell phone taking a picture? That is sort of an icon I'm going to use whenever I come across a slide I think is got some pertinent details on it. I'm going to put that up. We're going to call those the resource slides. You may want to just take a quick picture of your screen while you're doing it. Now, Greg, I know you've heard me do these further disclosures before, and I say I book 25 to 30 patients, but interesting after I get these reviews, the comments at the course. So many people will say, "God, I don't know how you do that when you see 30 to 35 patients a day." And others have said, "I don't know how you do that when you see 35 to 40 patients a day." I mean, I am not exaggerating. I do 25 to 30 patients a day, including the neuro-op. It's not 30 neuro-op patients by any means. Now, the question is, why do neuro-ophthalmology? Why do neuro-op, neuro-eye disease? Well, neuro-op is a financially rewarding specialty, said nobody ever. I am a convenience for our practice. The optometrists and ophthalmologists can send their neuro-op to me. Our local referral groups can send their neuro-op to me. But it doesn't bring a lot into the practice financially. It is a convenience really for everybody. Now, looking at claims per specialty in ophthalmology, the OMIG data, we see neuro is really low in terms of claims, but when you look at how much is paid out, neuro is #1. If you're talking neuro-oncology, just put those dollars right on top of each other. So there's a lot of risk involved here. But there are not enough neuro-ophthalmologists. Last year, there are 45 fellowships, only 25 filled. I think we all understand it's hard to get into neuro-ophthalmologist's office and people who are practicing clinically. It can be high risk because these patients have a tendency to want to get really sick and die on you. And you have to, think back to your training, optometry school, ophthalmology residency, fellowship, optometry residency. You think, is this urgent? Am I doing the right thing? Am I missing something here? Can it wait? There are some complications. It is neuro-ophthalmic disease, and you've got to remember the neuroanatomy. And one might say you don't have a lot of how can you say, ongoing patient relationships. A lot of it's diagnose and adios, where I make my diagnosis and get them in the hands of the right specialist. And it can be schedule busting, virtually guaranteed. Unless I've got a flight to make, one of my colleagues in the practice in another office, optometry or ophthalmology, calls me and says, I've got something I think I need you to see. I'm virtually 100% of the time going to do it. Just what we have to do. And I try to make up the time on an easy refraction and maybe a one-day post-op without complications. So we try to make up for it. But really, the big reason I think to do neuro-op is it saves lives. I can tell you in my practice, since I've been doing this, I have saved lives. I've saved lives every year. Not a financially rewarding specialty, neuro-op. There is no level 6 you can bill. There are no RVUs if you save somebody's life. There's no bonus if you save somebody's life. It's just part of doing the job. So this is why we do it. We can really have an intersection with our patients' lives. And what I want to tell you, and we're going back to the topic, nightmares and nonsense. In terms of neuro-op, 70% of what I see is nonsense. It's something strange, something unusual, an unexplained complaint. One of my colleagues wants a second look. They want another opinion, another set of eyes to look through it. So 70%, in fact, my last patient this week was a retired optometrist who was having double vision. Nothing serious, but we just needed another set of eyes to make sure that she was actually okay. So that's really what mostly what I do. Consults, straightforward stuff that a clinical neuro-ophthalmologist doesn't need to see, but 30% are nightmares. They're really bad things. And we're going to go through a few of those. So nightmare or nonsense. 23-year-old female, sudden onset pupil dilation with an ipsilateral headache. Medical history was normal. She's 20/20 in each eye. Pupils, there's 3 millimeters of anisocoria. The left one is larger. It's greater in bright illumination. She previously has been isocoric. There is no relative afferent pupillary defect. She does accommodate. It is reactive, but it is anisocoric. Remainder of her exam was normal, no double vision, no ptosis, no medication use, but she does mention a similar incident 22 days before that resolved within several hours. And this is what she looks like. You can see that, and this is a fundus camera that was used. You can see she has a significant anisocoria, pupils around. The pupil does react, but it is certainly much larger. So, Greg, that brings me to polling question number 1. Is this a nightmare or is this nonsense?
And Joe, I ran the test polling question while you were lecturing, and it was a fantasy football question. We have 20% to do fantasy football, and one was a fermented beverage question, and we have about 12%, but a few people thanking us for the reminder. So let me get that polling question opened up now. Is this nightmare or nonsense? And polling question number 1 is open, and it says nightmare because pupil diameter and headache equals aneurysm, or is this nonsense? Polling question are found if you look at your screen. There's chat, there's polling, there's course notes, and the survey. The polling question is found under there. So they are rolling in.
And of course, I'll call upon you to monitor the chat and let me know what the polls say.
Yep, I just opened up the chat and I wrote to everyone, it was a little bumpy on takeoff. It appears that we're at 10,000 feet on our way to cruising altitude. And thanks everyone for trusting us with your education, but nothing else is in there. And let's display this. We have 60%, Joe, that are saying A, nightmare because pupil and headache potential or equal to aneurysm. And we have 41% saying this is nonsense.
Excellent, Greg. That's a nice little split. And this falls in the category for me of nonsense. She has benign episodic pupillary mydriasis. This is actually a diagnosis. And I'm going to assert probably most people on this webinar have encountered this either directly or indirectly. About half of these I diagnose by history, because by the time they get into the office, they are now isocoric. It is a unilateral mydriasis lasting minutes to weeks. Generally speaking, it's several hours, accompanied by blurred vision, typically up close. There can be defective accommodation, and they can be headachy, but it's not really a typical migraine. It usually affects younger, healthy females. I've seen it in males, and is likely a migraine phenomenon. They have these peculiar sensations. They kind of know something is going on. But most important, lid and motility defects are not present. All right, there's no ptosis, there's no ophthalmoparesis. Now, one might say it could be pharmacologically dilated. Well, a parasympatholytic agent such as atropine will give no light and no reactivity. A sympathomimetic drug can mimic this, and he has to be ruled out. I came across a case like this I'm thinking probably a month or two ago, where it was a patient who was overusing a sympathomimetic eye drop, and she gave herself some anisocoria. So the pupil rules to remember: fixed and dilated and unresponsive to light or near. That's either iris trauma or it's a pharmacologic misadventure. So isolated dilated pupil without ptosis or motility deficit is not an emergency or even an urgency. It's trauma. It's a pharmacologic misadventure. It's a ganglionic lesion such as a tonic pupil. And here is a great example: David Bowie. People thought he had heterochromia. He did not. He had an isolated dilated pupil at age 13. He got into a fight with his best friend George Underwood over a girl, got hit in the eye. For the rest of his life, he had a mid-dilated pupil. Interesting, Greg. As popular as it is, I've only had one pickleball eye injury. And this is a woman after premium cataract surgery, got hit by a pickleball, and she ended up with a Bowie pupil fixed and mid-dilated. And unfortunately, several months after that, she ended up with a retinal detachment, but I think she's doing okay.
Wow. Well, hey, Joe, before you move on,
sure.
There was a good question that rolled in about your case here. Is this a variant of an 80s pupil?
No, because an 80s pupil is going to be persistent. These are really transient. Good question, though. And here's I think, really important case to illustrate why optometrists should try to embrace neuro-ophthalmic patients. Here's a pupil problem. He's a 14-year-old male who had an onset of blurred vision in the right eye in school. He didn't notice anything, but a classmate noticed it. His motility was fine. You can see he has no ptosis. He had a little bit of a headache. They go to the school nurse, who basically, I think, effectively pulled the fire alarm, called mom. She rushes over. They rush him to the emergency room. They're in the ER until midnight, and he underwent a CT of the head, non-contrast, which was reportedly normal. And if you wonder why they do that, Greg and I always say it's what they do. In the ER, everything is nailed because they only have a hammer. That's what they do. If they don't have guidance, they do a CT of the head because they're looking for a hemorrhagic stroke. So we take a look at him, and he's got a widely dilated pupil. I can put the BIO, do a peripheral exam on him. Mom looks like heck, so I can tell they were in the ER until midnight and probably didn't get home till after 1 o'clock. And she was feeling it from a long night. And no reactivity, no near, no light. I don't put pilocarpine. We just go through the history. Medical history: he had recently been sampled Qbrexza, glycopyrronium, which is an anticholinergic cholinergic agent for topical treatment of underarm sweating in adults and pediatrics. So this is the new age scopolamine patch. So whenever you think the fixed and dilated pupil, you ask about the scopolamine patch. Also ask about Qbrexza, glycopyrronium. It will cause a dilated pupil. So he was dilated probably another 24 hours. He had put it out, he had sampled himself, rubbed his eye, and there we are. So had the person come into the office first, there would have never have been an issue, no reason for the ER, and no reason to go through that waste of resources.
Joe, is there just a good, the part of this going back to your kind of pupil tips is that, this is fixed, it's dilated, there's no double vision, there's really nothing else neurological going on, and there's no ptosis, meaning. So now you're kind of going back to, okay, this is trauma or pharmacological or a ganglion, some type of ganglion lesion, cell lesion. So that would be kind of hard. So now you're down to something that's probably pharmacological, and you can ask, are they using any of these medications?
Exactly. And if it's a ganglionic lesion, a tonic pupil, you put you put the patient in the slit lamp, put the light in the pupil, turn it on and turn it off. You'll see kind of a sector paralysis or a stromal streaming as it does constrict. So a tonic pupil will react.
Are you talking about, when you talk about that, is that the ciliary ganglion behind the eye?
Yes.
Yeah, because for those who are old enough that, I used to work in an ODMD practice like Joe, and this was back when I first started. So I graduated in 1996, and they do retinal detachment surgery. Even at that time, maybe in some cases, they were still doing a retrobulbar block. And when they would do the retrobulbar block, they would inject back there, and there's times where they can inject, I guess, maybe into or around and destroy the ciliary ganglion, and then that patient would end up with a dilated. So that's kind of a pearl from the past. We don't really see that because it's all done topical nowadays. But I guess if someone ever had a retrobulbar block, that would be an incidence where you can get that fixed dilated pupil.
Entirely correct. History, history, history. Well, is this a nightmare or nonsense? 78-year-old male, acute onset double vision, horizontal, blurred vision, and dilated pupils bilaterally. He went to the emergency department. They worked him up for stroke, and they were looking for something. So he ultimately underwent, over his evaluation, a CT and a CTA and an MRI and MRA. You need to correct that. And all were normal. And I got a chance to see all of these, and everything was in order. All the proper tests were done, and all the proper things to look for had been done. And he'd been referred me by a colleague in our practice in another office. Now, when she saw him, he had quite a few complaints, as we just described. She referred the patient to me the next day. When I saw him, he said he felt his vision was improving. He felt his pupils were a little bit less dilated. He did have endpoint nystagmus and a very nonspecific horizontal double vision. Now, he is on an anti-muscarinic for bladder control, but he has not changed his medicines at all. So here's a person who's got dilated pupils, blurred vision, horizontal diplopia, and endpoint nystagmus. So that brings me to the polling question too, Greg. Is this a nightmare or nonsense? You're muted, Greg.
I was muted. Yes, thanks. So nightmare because there is too much going on for it to be nonsense, or it's just nonsense. Nightmare or nonsense. The polling question is open. I see the results rolling in, and I'll check the chat box, Joe, while that's happening.
All right.
I attended a CE where a lecture indicated that 80 to 90% of CT MRIs are negative. Can you confirm?
CT or MRI are negative. I'm not quite sure the context of that.
Yeah, I mean, yeah, to me, if you're maybe like Joe, or now that I've listened to so many neuro, that if we send them for MRI, as opposed to just sending everything for an MRI, I'd say that Joe's probably has a higher percentage of finding something because he's not sending everything that's out there. So I guess it probably would be a little bit more of, if you send everything that has maybe a neuro suspicion, then you're probably going to get 85 to 90% being negative. But, if you have someone that's coming in and you're feeling that it's not nonsense or it's more of a nightmare, going with tonight's theme, that you might have a higher percentage of
I,
positives.
I think you probably interpreted that question correctly, Greg. It reminds me, years ago I had to get a scan on the patient. It came back negative. The patient was upset, and they wanted me to refund them for the MRI. Said, "Hey, maybe next time you'll get lucky. It'll be a brain tumor. Get out of here."
Yeah. So, yeah, we
What's
did
our
get some
poll?
clarification, Joe. It says he was lecturing about optometry's fear of ordering CT and MRI. So,
Mm-hmm.
all right, let's go back to the poll. We're caught up there, and I'll display. And we have, it's a tight one. 48% saying nightmare because there's too much going on. We have 52% being nonsense. It's a close one.
Excellent. Well, here's my thought process on this situation. He feels he's getting a little bit better. That's always good. He has been imaged appropriately. I've looked at everything. Everything is in order. There's not much else for me to do. But the key in these patients is there's no magic. Sometimes, Greg, I will put a slit lamp up to their face just to make it seem like I'm doing something. But a lot of what I do is talking to them. So we now have to go back to the history. So mydriasis and blurred vision. That means two things to me. That means a toxicity. So whenever you have dilated pupils or blurred vision, you should think maybe there's a toxic reaction going on. So let's go back to the history. When did this all occur? He and his wife had driven nonstop from Connecticut all the way down to Sarasota, Florida, actually Englewood, Florida, a little bit further. Drove all the way down, didn't stop, only stopped to grab a bite to eat, get gas, and use the restroom. And they were fastidious about going to 7-Eleven because 7-Eleven had a special. If you bought a big gulp, you got it free refills. So they're hopscotching all this way from Connecticut to Florida at 7-Elevens getting big gulps. And we talked about it. And he probably drank about 4 liters of a Diet Dr. Pepper. Now, I will tell you my experience, and I've learned this from a friend of ours, an internist. Whenever a patient is asked about something they ingest and it's bad for them, whatever they say, triple it. It's triple what they're really intaking. So this sounded very toxic to me. My approach was, okay, I'm going to see you in a week. If anything gets worse, give me a call. If anything gets better, give me a call. 3 days later, I got a call. He said, everything's normal. I'm going to cancel my appointment. I said, that's a good idea. So always let the history come out. Let them sit back and just let them talk. It's not always a brain tumor. You got to think about medication toxicity. Blurred and dilated pupil, that to me is a systemic overdose of something. Probably a medicine that they already are using. But other things to be aware, ethambutol does cause a toxic optic neuropathy. They should be followed pretty closely every 1 to 2 months. Amiodarone or pacerone can be toxic optic neuropathy. And vigabatrin can cause bilateral constricted visual field. So there are a few medicines out there that have a special place in our hearts for potential toxicity. All right. Is this a nightmare or nonsense? And I just had a patient like this on Tuesday of the past week. So he is a 94-year-old male referred to me for a partial third nerve palsy. Left eye, he's got a little bit of subconch heme that is non-contributory, but you can see a mild ptosis and a mild adduction deficit, which is how a lot of these will start. Now, he's already been dilated by a tech in another office, and the optometrist didn't even get a chance to take a look. but was told by the tech that, the pupils were equal and reactive and there's no APD. Now, he has no head pain. He doesn't understand the concept of a headache. He's never had a headache in his life. He's got a pacemaker, he's hypertensive, and he's got kidney disease. So is this a nightmare or nonsense? 94-year-old partial third nerve palsy, already dilated, can't check the pupils, no head pain. But he's got a partial third. Is this a nightmare or is it a nonsense?
And Joe, you have down as the polling questions, A being nightmare because it's likely an aneurysm, nonsense as the risk of aneurysm is low, and it's nightmare-ish because of the dilation. So we have three
Excellent.
possibilities here on this one.
Mm-hmm.
Nightmare, nonsense, nightmare-ish.
I'm anxious to see what the audience response is here.
Nothing else has rolled into the chat box.
Good. And wherever possible, I'm going to share with you my thought process and why I did what I did on all of these cases.
All right, I think we have the trend going here. So let's see, we have 28 or 30% saying nightmare because it's likely an aneurysm. We've got 20% saying nonsense because of the low risk of aneurysm. Then you got your majority at 53% nightmare-ish because of the dilation. So,
and Greg, in my opinion, it falls onto the third. It's nightmare-ish for me. Let's go talk and take a look at it. Now he's got no head pain. That's very helpful. Aneurysms are virtually always painful. They leak and they bleed, and they irritate the meninges and touch pain-sensitive dural structures. So lack of a headache is helpful to me, but he's got a partial third. We don't know what's happening. Aneurysms develop over time, sometimes rapidly, but they begin not as a complete, but they begin partially. So we have to be considering a partial third should be an aneurysm until proven otherwise. But the lack of pupil involvement and the lack of pain is kind of very helpful to me here. So here's a rule. Please never dilate a patient with a third nerve palsy. Let your technicians know if there's any motility madness to come get you first. So I've had 2 of these, and the last one was just this past Tuesday. So partial third, questionable pupil sparing, but you can't unless you have a super tech, you really can't always just trust them because Perla is a very dangerous term. In the right illumination, anesocoria can be extinguished. A person can have a dilated pupil. If they're looking in the dim, they could be anesocoric. Patient could have a Horner syndrome, and if you look in light, they can be anesocoric. So you need to look in light and dark. Also, we have to look at how well does a pupil react. It may not be widely dilated. We're not looking for an 8-9 millimeter pupil from an aneurysm, but we're looking for a pupil that doesn't respond quite the same way as the other one. So that is why our touch is needed. But the quote-unquote lack of pupil involvement, no head pain was helpful in my threat assessment. And he is 94 years old. The average male life expectancy is about 80, so he has already won the game. Now, Bob doesn't want to go to meet his maker yet. I don't want to be the one to send him. Now, he needs imaging, a CT or a CTA or an MRI, MRA. And very important to remember that when you're looking for an A aneurysm, whatever you order, it has to have an A in it, a CTA or an MRA. Now, I'm not going to, I actually had to work through the ER with this patient because of his age and health history. Kidneys couldn't take contrast. They tried, they couldn't do it. They tried to get him an MRI, but the pacemaker precluded the MRI, but they did try all day. So he only got a non-contrast enhanced brain CT that said no bleed, which actually was kind of helpful to me. Not, and there's no intracranial hemorrhage. So they say you probably had a stroke, which is not really the right term. Now, I set him for a 1-week follow-up, and when these patients come in, I go to greet them in the waiting room because I want to see what they look like. Now he has progressed to a complete third nerve palsy. So a week later, he can't open his eye, he cannot elevate, depress, or adduct his eye. Now let's take a look at Bob. So this is the 1-week follow-up. Lift his lid. You can see he is isochoric. He can abduct. He can't adduct at all. He cannot elevate at all, and he cannot depress at all. So he's gone from a partial third to a complete third. So, Greg, this brings me to polling question number 4. Is this a nightmare or is this nonsense?
All right, you have, is it a nightmare or nonsense, with A being nightmare because it went bad on your watch, nonsense because this is expected. Let me check that polling or that chat box. All is quiet in the chat box. Let's see how that polling question's rolling in. It's rolling in nicely. I'll display the answer here very shortly. And I think the trend is in. So we have 60% Joe saying it went bad on your watch, so it's a nightmare, with 40% saying nonsense.
Well, good. That's great. Hopefully tonight we'll change, give some important information and change some thought patterns. I was expecting this, and that's why I go out to meet these patients in the waiting room, because I want to see what they look like, or I want them to walk by me when they go to their room with the tech. I expect this to happen. If this is ischemic vascular, here's what's going to happen. They're going to get worse over the course of a week. They won't get worse, they won't be better in 2 weeks. And then nothing happens. But I expect ischemic palsies to progress like this. I expect to have a complete palsy. Now, imaging was insufficient, not what we needed, but at least there was no intracranial hemorrhage. Now, if there was an aneurysm that had bled, that could get picked up. So it's most likely ischemic vascular, and they'll be about 50% improved at 6 weeks and pretty well recovered around 12 weeks. Now, I look for aberrant regeneration. If that's present, then we have to look for another cause, because that doesn't happen with ischemia. But this is what should happen. These ischemic palsies will worsen over the course of a week. Do not be worried about that.
Hey, Joe,
Then
can I just clarify something real quick,
Yeah,
so that you
sure.
can say it? Is that you're not just talking about a third. This also happens with 6 and with 4, because I just had a 6 come in. Hey, it started on Saturday. I saw them on Monday. They were kind of limited, being pulled out there, and then all of a sudden, boom, they're ESO a week later. So can you clarify at least, or say that I'm correct, that's for 3, 4, and 6?
You are correct. Now, on the 6th nerve palsies, what you don't want to see is a person at a week a little bit worse, but not stuck at midline. And then at 14 days, now they're a little bit worse, and 21 days are a little bit. That's not ischemic. It gets worse over the course of the week. That's 4 and 6 and 3. Now let's look at Bob. And what will happen is they'll get worse for a week, then nothing will happen for about a month. I can tell you, close follow-up in that period is like watching paint dry. Give him about 6 weeks after that, and then we'll see. Now, here he is at 11 weeks. Ptosis is resolved. He can abduct. He can elevate. He can depress. He can adduct. He has a little bit of double vision when he lies on his side in bed, looks at his alarm clock, but that's otherwise he is resolved nicely. Nightmare nonsense. 70-year-old male comes in, sudden onset retroorbital pain followed by double vision for about a week, getting progressively worse over the course of a week. He's hypertensive and diabetic, high cholesterol, all being treated. 2030, 2020, and this was the day before Hurricane Ian. Now, we just had 3 hurricanes in a row in the last couple months, and the third one hit my house dead on, category 3. But this was about 2 years ago, and Hurricane Ian was a bad one. And this is one where everybody is shutting down. He was one of our last patients. I saw him across the waiting room, saw what he looked like, knew exactly what I was dealing with. Yeah, let's take a look at him. Now, let him go. He droops. Complete ptosis. He's isochoric. Can abduct, can't adduct, can elevate, can depress. So is this a nightmare or a nonsense? What do you think, guys?
Okay, polling question is open. Nightmare or nonsense? Nightmare because this one is an aneurysm. Nonsense because it's probably ischemic. They're all nightmares to me.
Maybe all good number of choices there.
Let me check the chat box. Nothing there.
And guys, feel free to write questions. I want you to get out of this what you want to get out of this. I want to make sure that you're comfortable with all of this.
All right, I think the trend is in. A, nightmare because this one is an aneurysm, 44. Nonsense because it's probably ischemic, 32. They're all nightmares to me, 24. So we got winning is A. So go ahead. Sorry.
Oh, you said so that nightmare?
Yep, nightmare.
Okay, so we have an older person, complete third nerve palsy, isochoric, reactive pupils, ischemic vascular diseases. The risk of aneurysm here is actually pretty low, but the challenge for me, and I will tell you, these patients all need to be imaged. To me, I think we'll agree, every third nerve palsy needs to be imaged. Problem is everything's shutting down. This is the kind of person I would image on an outpatient basis. I would have my staff bully him onto the local imaging center in a day or so, just to make sure. But everybody's shutting down. We're like rats off a sinking ship. So unfortunately, we had to do this. Well, not unfortunately, we had to do this for the hospital. And what he needs is CT, CTA, or MRI, MRA, because we're looking for an aneurysm. Presumptive diagnosis, microvascular ischemia. His imaging was normal. We survived the hurricane, but we did take a whipping that year. And about 6 weeks, he is markedly improved. But the challenge for these patients, when third nerve palsies are developing, you're going to first see a ptosis, not complete, and an adduction deficit, not complete. Then it goes complete. Then when they start to resolve and they start to improve, the ptosis resolves first before the motility, thus they become diplopic. So they have to understand they're going to have to patch, and don't try a prism. It just won't work. Now, pupil-involved third nerve palsy is a posterior communicating artery aneurysm until proven otherwise. The really only true emergency that optometrists and ophthalmologists will see. They need stat ER admission. And incomplete palsy is an aneurysm until proven otherwise, regardless of the pupil. It could be developing. Now, 30% of third nerve palsies are caused by aneurysm, but I want you to think there's a 1 in 3 chance. It's not true. There are patients who, based upon the clinical features, have maybe a 5% chance of being caused by an aneurysm, and other patients, based upon their clinical finding, may have a 90% chance. And pain is pain. It's only helpful when it's not present. Aneurysms are always painful. Ischemic palsies are painful 90% of the time. So it's only helpful when it's not there. We can't qualify it. We can't say that an aneurysm is a debilitating, boring, thunderclap hemicranial pain. That's not really true. Case in point, Temple University football player develops third nerve palsy, a little bit of headache, aneurysm. Little old lady, worst head pain of her life, diabetes. Vasculopathic thirds will resolve in time. 6 weeks, they're going to be about 50% better. 12 weeks, they should be resolved. But aneurysms will likely rupture in time. Now, here's another patient that I just saw this week, was seen by a colleague in another office, and he comes in, he's got a partial third nerve palsy. And as I said, if you notice, the first things you see on the developing thirds, and of course he had been dilated by the tech before my colleague saw, you have the ptosis and you have the adduction deficit. Maybe a little bit of supraduction issue. I can't tell infraduction. Abduction is going to be fine, and maybe a little supraduction issue. But generally speaking, ptosis and medial rectus are what usually occur first. And of course, he was pharmacologically dilated, so we lose that diagnostic capability. Now, I saw him on Tuesday. Here's what he looked like on Tuesday. Again, what I was expecting to see. And when he was there, I waited till he walked, or he was already with my tech. I just walked in because this is what I want to see if we're dealing with ischemia. Lift him up. Can't look up now. Can't look down. Can't abduct. Can't adduct. And his pupils were small. He has like maybe 3 millimeter pupils, but they equally reacted. And with small pupils, I put them in a slit lamp. I turn the light on each pupil and look at it up close to see do the reactions look the same, and they did. So presumptively he is ischemic, but still I am trying to get a CTA on him.
Joe, a quick little
Yeah.
pearl that I can give is I have an anterior segment slit lamp, and I can do infrared pictures, which means I don't need to have light. We do that for the meibomian glands. So a little trick that I was going to tell you at one of our next kind of face-to-face, but this is a good time to do it, is that I use my anterior segment camera because I can turn the lights off. The infrared can see everything, and then I take pictures because there's no light needed. So I can really check those pupils in the dark and see what's happening with those pupils. That's kind of a neat little trick for those who have this kind of infrared or maybe anterior segment that's out there.
Oh, that's terrific. Now, rules for third nerve imaging. Digital subtraction arteriography is a gold standard, but CT and CTA is a preferred non-invasive imaging for third nerve palsy. Easier to get on the schedule. CT is good for subarachnoid hemorrhage. Now, CTA does require contrast. And if they're renally impaired, an MRI or MRA is going to be better. CTA is better if they can't have an MRI, if they've got a pacemaker or they're claustrophobic. And the MRI is superior if you're wrong, there's something else like inflammation or tumor. And the MRA adds very little time to the scan. Now, a study came out recently in Neuro-Op, and they showed the majority of third nerve palsies do not get the appropriate urgent imaging. Now, is this a nightmare or nonsense? 63-year-old male, sudden onset of orbital pain for 3 days duration. Begins on a Friday, gets worse on a Saturday, worse on a Sunday, comes to see me on Monday. Diabetic and hypertensive on Coumadin with a pacemaker, and we see he's got a partial ptosis. When we lift his lid, he can't look up, he can't look down, he can abduct, but he cannot adduct. And when we look at his pupil, he is 5 millimeters fixed and unreactive in the right eye, and 3 millimeters briskly reactive in the left eye. So, Greg, it brings me polling question number 6. Is this a nightmare or is this nonsense?
And that's all you have, Joe. You have nightmare or nonsense, and A is nightmare, and B is nonsense.
See, for the audience, we're going to keep the questions very easy. For the most part, it's going to be just two options. Wouldn't be
All
so
right.
much better.
I got two questions in there.
All right.
Question one was, what did the hurricane have to do with it?
The hurricane just prevented me from doing outpatient imaging, which I would have done through a local imaging center. The only thing that's going to be open was a hospital ER, so he had to go through there.
And what do you order for scans?
It all depends on the patient, but probably easiest and best would be CT and CTA, followed by MR, MRA secondarily. And in a perfect world, we would get MRI, we'd get all of them. The perfect device doesn't exist, but it's one device that the patient sticks their head in, and it does a CTA and an MRI. Fortunately, we don't have that device yet.
So, Joe, when you're saying that, you're saying, CTA, MRI, MRA, is that orbits and head?
What I'm doing, not doing orbits, we're doing head, brain, but I'm specifying what I'm looking for.
Okay.
And the reason we do this is we're looking for an aneurysm of the circle of Willis.
Are you doing any fat suppression on the MRI?
I'm not, because I don't really care much about the orbit.
Okay, so just my question was about the orbits and MRI. This question came in about fat suppression. Fat suppression is pretty much just if you're the neuro guy, not me, but when you're just worried about the orbits, when you're looking for that optic nerve in that fat, and you need to suppress the fat to see if the optic nerve is. But when you get back to the head, fat suppression is not so critical. Is that correct?
That is correct, Greg.
Okay. And then
So
do
what
you
is
have any specific cuts that you're ordering?
No, I tell them they get the diagnosis, third nerve palsy. They get the attention to circle of Willis, and they get rule out posterior communicating artery aneurysm.
And I can throw in a little bit of, I definitely feel more comfortable again, 4 or 5 years listening to neuro lectures, having Joe as phone a friend if need be. The phone a friend has kind of declined since 4 years ago to now. Is that probably my best advice is and I use an external imaging center. They know me well over there. They know I'm a doc in the community. I've been here 29 years. I help them. They help me. So I call them up and I say, look, I have a third nerve palsy. It is recent onset. We just need to rule out an aneurysm. So CT, CTA, based on whether they have pacemakers and all the other stuff, or if you can do MRI, MRA. But I'm really looking, because I have a third nerve, for that aneurysm. Those neuroimaging people usually know, okay, doc, thanks for that call. I will rule that out for you, and they'll get exactly what we need. Tweaking it, whether it's fat suppression, not fat suppression. In this case, you won't need it, but they know what you're looking. If you call them and tell them what you have and what you're looking for, they're usually all over it. My advice
Indeed,
is to call.
that is correct.
And Joe, you're all caught up on your questions. Now let's go back, because I think we have a polling open, and we have 91 going nightmare on this one.
Very good. And that is a nightmare. Pupil involved, right? Pupil involved third nerve palsy from a likely aneurysm. And why is this important? 50% of these patients will die from aneurysmal rupture. Blood fills the cranial vault. There's only so much room. Brainstem herniates down through frame and magnum. Respiratory center collapses. They die. So half these patients will die within 29 days, and 20% will die within 48 hours. Now, the pupil issue is because the pupil motor fibers coat the third nerve, so they are prone to external compression. And that's why the pupil becomes irregular, mydriatic, or poorly reactive. That's the more important thing. However, in ischemic insult diabetes and or hypertension, hypercholesterolemia. Those fibers coat the third nerve, and they're relatively immune to they have a blood supply to them. But the core of the nerve will actually infarct while the pupil still remains relatively reactive. But the key is there can be a little bit of anesocoria with a diabetic infarct. The issue is the reactivity. It should have normal reactivity. In subarachnoid space, the posterior communicating artery runs parallel and very close to the third nerve. Now, this is where the issue is in the circle of Willis. Mostly it's a posterior communicating artery aneurysm because the third nerve falls very close. And now you can have one at the tip of the basilar artery. You can also have one at the junction of the posterior communicating artery and internal carotid artery. But it's a relatively tight neighborhood. You tell them where you're looking, what to look for, and they're looking the circle of Willis for an aneurysm, they will find it. Now, because 20% will die within 40 hours, they need emergency care. Time counts. Why not just send them to the ER? Well, this is your typical ER physician encountering a patient with an eye problem, and she only has conjunctivitis. Now, they need our consult. They need our help. Otherwise, they're going to get a non-contrast enhanced CT of the head, and if there is no bleeding, they're going to be released. I had an ER physician as a patient not all that long ago. We had a discussion, and he told me all the specialists he does not have access to consult with. He said, look, if you can tell me something that I need to be aware of, you're my ophthalmology consult. Tell me what I need to know. Just because they stick their head in a tube doesn't mean the cause is going to be found. The world's best neuroradiologist can't help if you don't order the scan, order the right scan, and tell them what to look for. So this is a situation that he needs to go to the ER, but they need help. He goes to the ER, detailed notes, my recommendation, and my cell phone number. I tell him, tell the physicians there to call me, or if these things are not happening the way I expect them, I want you to call and tell me. And I call the triage nurse in advance. And I tell them, you're not going to wait in line. You're going to get the Disney Fast Pass. You're going to get right on the ride. I remember, and whenever this happens, I talk to the triage nurse, and they'll say, patient has a pupil-involved right third nerve palsy, most likely caused an intracranial aneurysm in the posterior communicating artery. And by the time I get that far, if I get that far, I usually get the response, could you hold on for the doctor? I want you to talk to the physician on the floor. I say he needs a CT, CTA, because he's got a pacemaker, and a neurosurgical consult stat. I got a call. Within 45 minutes of walking out the door, he was in the scanner. He had a leaking but unruptured aneurysm confirmed with CTA. He was hospitalized for 23 days and had 2 endovascular coil packing successfully. His ptosis improved, motility and pupil didn't, but he did live. Remember, neuro-op saves lives. And this is what happens. There's 2 approaches. There's a craniotomy. They actually put an aneurysm clip on, like a clip on a bag of potato chips. Or they can do through the femoral artery with a stent. Sometimes they need to put a stent in there with a catheter. And they squeeze these coils in like toothpaste, and they give a little electrical shock, and it cuts them off. And they keep packing. And if blood can't get in there, the likelihood it's going to rupture is very low. Now, I used to always say these are 2 relatively straightforward procedures in the hands of a skilled neurosurgeon. And one day, some time ago, I had a retired neurosurgeon as a patient. So we had a conversation. She was saying, yeah, we hate aneurysm clips because you open up you open up the door and it's all bloody. You can't see what you're doing. Then you touch the aneurysm and it pops. You got blood all over the place. Really, they just do the endovascular coiling at this point. Now, here's a patient. Beware of the pre-existing diagnosis. She went to a colleague who said, I have another Bell's palsy. And she's suffered from Bell's palsy before, and she said, my Bell's palsy has recurred. So the person doesn't do neuro, so the patient was sent to me for her recurrent Bell's palsy. And let's just take and see, she does have residual from a Bell's palsy, but when I lift the eyelid up, what do we notice? She's down and out. She can't look up. She can't look down. She can abduct, but she can't adduct. And this is a very poor demonstration, but she had a fixed and dilated pupil. This is the big bad. She gets the Disney fast pass and she goes right to the ER. Now, here's what you do and don't say to the ER doc. You don't say the patient has double vision. They're going to get a non-contrast enhanced CT. They're not going to get a neuro-op consult, neurology consult, or ophthalmology consult. What you say is the patient has an aneurysm, the posterior communicating artery is going to die if they don't get to neurosurgery immediately. And they are appreciative of the help. And this is how we have a good outcome here. Now, I'm going to do a little bit of neuroimaging for the primary care optometrist. Disclosure, I don't read MRIs. There's some that do. I'm not one of them. What you don't know can hurt you a whole lot. That's why there's residencies in radiology and subspecialties in neuroradiology. Think I'm as good as they are? I think is just irresponsible. I did a conference. We had a neuroradiologist. He actually showed on an MRI the ciliary body. That's how good they are. So rules to eye care practitioner: order the correct scan and read the report to make sure the right thing was done. If you have questions, doubts, or concern, reach out to the radiologist. Ask them to look at, have a conversation. They're accustomed to doing this. And as Greg says, get a relationship with the imaging center and find out about the practice. They may have better results with MRA and others may have better results with CTA. But the conversations is what are what you need. So here's a resource slide for it if you want to take pictures of it. What to order, why, and when. Disc edema or suspect papilledema. Brain MRI with and without contrast, looking for mass lesion, hydrocephalus, hemorrhage, flattened globe, and empty cella. MRV, additionally, looking for cerebral venous sinus thrombosis. And yes, I write all of this on the note. Optic nerve chiasmal disease, MRI orbits and chiasm, with and without contrast and fat suppression, because without fat suppression, you're looking for a snowball in a snowstorm. Now, optic nerve disease, you need to have a brain MRI as well, because of the length of the optic nerve. The only way to image it properly is have orbits and chiasm and brain. You want to have that whole visual pathway. Optic neuritis, suspect MS, MRI orbits and chiasm with and without contrast with fat suppression, MRI brain with and without contrast. Also, we need MOG and aquaporin antibodies, but that's another lecture. Horner syndrome, brain MRI with and without contrast, CTA or MRA of the head and neck looking for a cerebral artery dissection, MRI of the chest with lung apex and brachial plexus. These are 3 different scans. If you don't know, as Greg says, reach out to the center. Tell them what you have and say, do you have a Horner protocol or can you just image the sympathetic plexus for me, please? And suspected aneurysm, that we just talked about, whatever you order, there has to be an A in it. And if it's a high risk of aneurysm, send them to the ER and tell them what to do. But don't just send them to the ER without helping. They often won't get it right. Here's an 83-year-old. Here's a partial third nerve palsy. I saw the patient on follow-up when he had a complete third nerve palsy, diabetic, less blood sugar in the 300s, A1C around 11. Pupils were normal. And the MRI had been ordered through the PCP. And when I looked at the MRI report, it said indication for imaging brain ischemia, not look for an aneurysm, but brain ischemia. There were 2 mistakes here. That was one mistake, not telling the radiologist what to look for. The other mistake was there's no A in MRI. You needed an MRA or CTA if you're looking for an aneurysm. And if you're imaging these patients, that's what you're looking for. That's why you're imaging them. You're looking for an aneurysm. Anything come in, Greg?
Nope, you're good. I have a person that got booted off, and I'm going to try and help them get back on.
All right. We're gonna have a polling question coming up fairly quickly, though. 64-year-old female. I get a call from Venice Regional Hospital ER physician Friday at 3 o'clock. He tells me patient woke up blind in the left eye, but has had some improvement throughout the day, has an APD. He was very proud of himself. He said, there's an APD. I saw it. He was very pleased. So we did a head CT. It's normal. Can you, and he's saying, no, I know it's getting late. It's Friday. And it's probably going to be hard to get the patient seen. I said, do you want me to see the patient for you? He said, yes, please. I said, okay, send the patient over. If it's strictly ocular, we will handle it. And if it's not, I will send the patient, but I'll tell you what we should do. So she comes over 20 minutes later. She's 20/25 and 20/30. There is a marked afferent defect. She has a pale swollen optic nerve. We see the visual field. And yes, do visual fields are very helpful. She does mention when I asked her 15-pound weight loss and a frontal occipital headache and malaise, but she blames everything on a COVID infection she had several weeks earlier. And she looks like this. Is this a nightmare or is this nonsense?
The polling question is now open. And Joe, you just have a pretty straightforward nightmare or nonsense. A is nightmare, B is nonsense. The answers are rolling in. I'll jump to the chat box. You're caught up in the chat box. The answers are rolling in here nicely. Remember, the polling question is on the right side, second one down, right below the chat box. And let me display the answer. We've got I think a pretty convincing trend here, Joe. We got 93% going with nightmare.
Very good. This is, along with third nerve palsy, the other true emergency that we see in eye care. She has an arteritic anterior ischemic optic neuropathy, likely from giant cell arteritis. I am not going to handle this myself. I'm going to make the diagnosis and adios. She's going back to the ER from whence she came, but with my recommendation. I called the triage nurse and I gave my cell phone number and say we need to have a SED-rate, C-reactive protein, and platelets. And she got the Disney Fast Pass right back to right into the suite. And a couple hours later, I got a call from the ER and they said SED-rate's 96. What do we do now? The other tests weren't back yet. He said, what do we do? And he wants me to walk him through it. And I said, well, admit the patient, begin the patient 250 milligrams IV Solumedrol every 6 hours for 3 days, get 12 doses in, followed by 60 to 80 milligrams of oral prednisone until you can get him to see rheumatology. Now, the patient needs a biopsy or an ultrasound. Do you want me to help you arrange that? And if they're in the hospital, they'll usually get a biopsy. If I'm doing this outpatient, I do ultrasounds. He thanked me for my time, and we ended our phone call. And about 2 hours later, I got a call from the hospitalist who was admitting the patient, and she had the same questions, like, what do I do? What's the dosing? How do I dose? How long do I keep him on it? What do I do when I let him go? And what's the follow-up? Same questions. And they are very, very, ER, gunshot wound, motor vehicle accident, heart attack, stroke, great place to be. Eye problems, they're a little bit uncomfortable, but they will accept our help. And I just walked her through. If you can walk them through, that saves them having to Google it. So she had anterior ischemic optic neuropathy and hypoperfusion of the ciliary circulation of the anterior optic nerve. It can be arteritic or non-arteritic. Now, in non-arteritic, ischemic vascular disease and other mechanical factors are going to play a role, whereas an autoimmune vasculitis contributes to the arteritic version. It is a unilateral presentation, typically initially, but a high incidence of subsequent contralateral involvement with arteritic ischemic neuropathy. If you feel you're seeing a patient with a bilateral ischemic neuropathy, it is not non-arteritic. It is virtually always arteritic, unless the patient has had a severe hypovolemic crisis. Now, looking at these, you might be able to differentiate the non-arteritic ischemic neuropathy. Has got that small crowded disc at risk and is usually hyperemic in a sectorial manner, whereas arteritic tends to have a pale, swollen optic nerve, and the vision loss is often very disproportionate to the what you see in the fundus. It doesn't look all that bad, but it's got precipitous vision loss. Now, non-arteritic risk factors are high blood pressure, diabetes, atherosclerotic diseases, smoking, sometimes after cataract surgery, and the existence of small optic nerves. They actually had a paper come out that looked at patients of African descent with non-arteritic anterior ischemic optic neuropathy. And yes, it does happen in patients of African descent. It is not common because these are patients who have larger cupping, typically. And in those patients that did, they all had very small crowded disc at risk. So, regardless of race, it's the small crowded nerves that are a risk factor. And yes, we're seeing a little bit more of that with the Ozempics and the phosphodiesterase inhibitors, but again, it's a very small number, very small number. So, and it's not even really conclusive. 6 to 1, they'll have an inferior arcuate defect. They have a hyperemic swollen nerve. The other eye is a disc at risk. They get a 0.3, 0.4 CD ratio. This is not a diagnosis you should entertain. 98% of patients with non-arteritic anterior ischemic optic neuropathy have a 0.2 or less CD ratio, and the other 2% were misdiagnosed. It can be progressive. The nerve is edematous. You can have progressive vision loss, and there is some potential recovery at 6 months of a few lines of acuity. The youngest I've ever seen this is in the late 30s and early 40s, but it goes all the way up to death, and it is a painless disease. Arteritic ischemic neuropathy is a pale swollen nerve, pain of some sort, head pain, jaw pain, neck pain, facial pain, scalp pain, with severe dysfunction, very similar if you can measure it, often inferior arcuate defect. Giant cell arteritis and polymyalgia rheumatica are risk factors for ischemic neuropathy. Average age is about 72, uncommon under 60, but it does happen. Any patient over age 50 is at risk. And I said high risk bilateral involvement, 65% within 10 days will have bilateral involvement. So when a patient comes in with unilateral involvement, our goal is to prevent bilateral blindness. In patients who have large vessel GCA, they come in with headache, scalp pain, jaw pain, but no vision loss. Our goal is to get them diagnosed and not have any vision loss. So got to do a good history. You got to ask about the non-visual symptoms, headache in over 90% of patients, scalp tenderness, jaw claudication, but it's not pain on chewing. The jaws get tired. They begin to ache like they're eating tough beef jerky. Ear pain, arthralgias, temporal pain, tenderness, malaise, intermittent fevers. Of course, we're going to do our examination and we're going to do some blood studies. Very simple to do. I order these all the time in patients who I have a suspicion might be harboring giant cell arteritis, not the patients who have an ischemic neuropathy and artery occlusion, but the older person who's got an unexplained headache or some temporal pain or jaw claudication. I order those all the time. I say you can go into Quest or LabCorp. They don't need to be fasting. You just walk in and get it done. SED rate, C-reactive protein, and platelet count. Elevated SED rate can be lowered by statins and NSAIDs. So we got to watch out for that because a lot of our patients are using them. C-reactive protein is produced by the liver, not affected by statins or NSAIDs. And many of these patients will have an elevated platelet count as well. Now, initial symptoms in giant cell headache, we talked about that. Polymyalgia rheumatica. Think hair, chair, stare, and fair. Hair hurts when they comb their hair. Chair, tough for them to get out of the chairs. Stair, tough for them to walk upstairs. And fair, I put a question mark in there because we've always thought this is a Caucasian disease. And the reality is that comes from a population-based study where the majority of patients with giant cell arteritis were Caucasian. But that study was done in Olmsted County, Minnesota, mostly Caucasian. When you do it in Baltimore, with a more mixed population, about a third of patients with giant cell arteritis were patients of African descent. Fever of unknown origin, visual symptoms without vision loss, TIAs, they have little blackouts, or they have intermittent double vision that doesn't follow an ischemic course, which may not even be happening in the office. They can have weakness, malaise, fatigue. Now, what do these all have in common is they can have a normal examination. So we have to look at the symptoms. Vision loss and ocular findings, ischemic neuropathy, artery occlusion. Posterior ischemic optic neuropathy is almost always temporal arteritis, but it's not a very common finding. TIAs and transient double vision, which may not even be happening in the office. So when we look at the vascular distribution, the temporal artery, ophthalmic artery, facial artery, lingual artery, occipital artery, really the pain can be anywhere. Temporal, occipital, neck pain, ear pain, jaw pain, scalp pain. So a lot of times patients, they have it on the top of their head or in the back of their head. It's not always temporal pain. Now here's a resource slide. You can take a picture of this. I'm not going to go through everything. Sed-rate C-reactive protein is very, very sensitive and very specific. Platelet count is very helpful. I don't usually order anything beyond that. Now, in patients undergoing temporal artery biopsy, not all pathologists are created equal. I've seen positive biopsies initially interpreted as negative. Maybe well, first off, 50% of patients won't have giant cells. Sometimes there's bad pathology. Sometimes you get the report back that says, temporal vein is normal, you idiot. But you need to read the report. They may say no giant cells, no active arteritis, but if it says focal interruption of the internal elastic lamina, that's a healed arteritis, they've got the disease. Nowadays, on an outpatient basis, I order temporal artery ultrasound. I've got a vascular surgeon in the Sarasota area, who is very responsive to getting this done. And temporal artery ultrasound is really pretty close to, or virtually the same efficacy as temporal artery biopsy. And in fact, in Europe, they're not really doing biopsies any longer. They're just doing ultrasounds. Now, here is the dosing that I give you. Best if they have vision loss, ischemic neuropathy, do it through the ER. Tell them 250 milligrams Solumedrol 4 times a day for 3 days, 12 doses, followed by 60 to 80 milligrams of oral prednisone until they can get in to see a rheumatologist. Now, tocilizumab Actemra is a biologic steroid-sparing agent that is used, but they're not going to do that in the ER. That is only done by rheumatologists. Very expensive, restrictive formulary, and nobody's really sure when to actually stop that. But steroids are the mainstay. So take a picture here so that if you have this, you can tell the ER physician what dosing to use. Non-arteritic is diagnosed in the negative. It's only diagnosed by what it isn't. It's a clinical diagnosis, but how do you want to say it's not arteritic unless you've proven that it isn't arteritic? So I will always get the test done promptly with any ischemic neuropathy. And remember the E's in GCA. Their elderly ESR is E elevated. They only see the big E on the EI chart, and it is an emergency. 66-year-old female, no onset vision loss. Now she's 2,400.
Hey, Joe, hold on one second.
Yeah, sure.
There is a question that rolled in. I think it's way back at the beginning with the person that you ended up sending back to the ER. A question rolled in that said, did the ER get any blood work? I think that's where it is.
Initially, they did not. I think they did a CBC, but they didn't do a sed rate or C-reactive protein. When I sent them back, I told them what the thought process was. It's not a retinal detachment. She's got an ischemic neuropathy. It's probably temporal arteritis. Let's proceed for there. Anything else?
Nope, that's it.
All right. Well, she's got 2400, but it's long-standing 2400 because she had a macular scar. But she noticed her visual field had changed over the course of a day. She had a new onset inferior arcuate scotoma. Now, looking at her, she's got disc edema, some pallor, no hemorrhages, no telangiectasia. Her left eye is a small crowded disc at risk. CD resh is less than 0.2. She's got a mild headache relieved by an over-the-counter analgesics, little malaise, little loss of appetite, has lost about 7 pounds over 4 weeks, no jaw claudication, no temporal head pain. What do we do? I can tell you this woman was not in distress. She was a typical Sarasota suburbanite. She was actually in the chair in her tennis outfit. So you may say, okay, she's got inferior loss. She's 66 years old, disc at risk. This is probably nothing we need to worry about. Well, this is exactly what we worry about. She was sent to the ER with instructions. Her SED rate was 96. Within 3 hours, she was in a hospital bed with steroids flowing into her arm, preserving her fellow eye, which was her good eye. Any acute vision loss in the elderly is giant cell until proven otherwise. And definition of elderly is 50 and above. Don't hate the player, hate the game. That's what the literature says. So what do you say to the ER doc? You don't say the patient has blurred vision. You say this elderly patient has suddenly lost vision in one eye and will go totally blind from giant cell arteritis if they aren't treated with steroids immediately. And that should make them sit up and take notice and listen to what you say. Well, is this nightmare or nonsense? 78-year-old male undergoes premium cataract surgery, comes out 2025, J1, but develops intermittent horizontal double vision at distance. Worse when he drives at night and watches baseball and basketball on TV. He's a little exophoric at near. He is a bit esophoric at distance, and he's common in right and left gaze. Is this a nightmare or nonsense? "78-year-old undergoes premium cataract surgery successfully. Then he develops intermittent horizontal double vision. Worse when driving at night and watching his TV. He's a little exo at near and a little eso at distance."
And you have multiple answers for this polling question. Number 8, nightmare because this patient has myasthenia gravis. Nightmare because premium IOL patients are always nightmares. Nonsense because this patient has decompensating for you. I think this patient has something else and it's a nightmare. I think this patient has something else and it's nonsense.
All right, this was a little tougher one.
So we have 5 different answers. Oops, I don't think I opened the question. I forgot to open the question. That's my fault, audience. Sorry.
No worries.
All right, now they're starting to roll in, Joe.
Excellent.
Nightmare because the patient has myasthenia gravis. Nightmare because premium IOL patients are always nightmares. Nonsense because this patient has decompensating for you. I think the patient has something else and it is a nightmare. I think the patient has something else and it is nonsense. Let me check the chat box. Yeah, thanks, William. Where's the poll? Yeah, I forgot to open it. Now it's open. All right, looks like we got the trend rolling in here.
What is the trend?
And we got 3% saying myasthenia gravis, 17% saying premium IOLs are always a nightmare. Your winner is nonsense because it's a decompensating for you. We've got 12% saying It's something else and it's a nightmare. And then we have 26%. It's nonsense. But it's something else.
Now, there are two, in my opinion, there are two good answers. One, it's nonsense because it's something else, and the other answer is premium IOL patients who aren't perfect are always nightmares. I'm gonna give you some neuro-op nonsense that can be really helpful. The sagging eye syndrome. Sometimes they call it saggy eye syndrome. Uh, doesn't have a good name, but it's what we historically have said is a decompensating phoria. But what if the patient doesn't have a phoria? What if they never had a phoria? How do you have a decompensating, phoria if they didn't have a phoria? This is something I come across probably once or twice a month. The sagging eye syndrome. Because I get the patients who are referred to me for double vision. And we've always thought with double vision, we got nerve, we think muscle, we think neuromuscular junction, but what we don't think about is connective tissue, tendon. And this is a tendon issue. These are people that often have baggy eyelids, or what I see is they're really deep set sulcus. Maybe they've had a blepharoplasty before. These are people who are prone to this lateral rectus superior rectus ligament, which links the lateral rectus and superior rectus and holds the eye in the place in orbit. It tends to stretch or degenerate, or sometimes it even ruptures. Now, sagging eye syndrome is really a manifestation of an orbital connective tissue degeneration. It allows the eye to sag. Now, this is a mechanical cause and acquired adult horizontal and sometimes vertical deviation. This is a nice lateral rectus superior rectus band. Sometimes it elongates, sometimes it ruptures. MRI is confirmatory. It is not diagnostic. I don't order MRIs looking for this. I just look for the clinical picture. This is what we would always call the decompensating phoria, but it's not really true. It's really an age-related dehiscence and sag of this pulley system, this tendon. So common findings: horizontal double vision, worse when they're tired. And I will say, I will do a mea culpa, Greg. I went to the well once too often last year. One of my sagging eye syndromes on follow-up did turn out to be myasthenia gravis. But worse when they're tired, mostly when they're driving and driving at night. And the reason is they look left, they look right for the side view mirrors, and that challenges them. Watching TV at distance, they get fatigued, it will get worse. Also, if they're doing things that require saccadic eye movement, watching baseball, basketball, tennis, that will tire it out. Mostly they're ESO at distance, a little bit EXO at near. It's comitant. There's no restriction of motility. You can have a vertical deviation as well. As I said, MRI is confirmatory. It's not diagnostic. I treat these patients with Prism. And sometimes there's a wow factor. Now, if they are not the diplopic in the office, it's a little tougher to do. If they can achieve some mild diplopia in the office, is a little bit, and they do well with Prism. This patient, I gave him two base out in some driving glasses. I tried a Fresnel Prism first, and usually if they don't wear glasses, I send them down to a Target or a Walmart to get some blue blocking glasses so I can have something to support the Fresnel Prism. It did help him a lot, but he was still peeved that he had to wear glasses. Now, I just saw him a couple months ago, and this all happened a few years ago. When I saw him a couple months ago, he said, "Man, I hardly ever get double vision anymore. I'm fine. I really don't even wear the glasses." So remember sagging eye syndrome, EXO, ortho at near, ESO at distance, combinant. They like base out Prism. All right, we're going to come down into our final stretch here, Greg. Nightmare and nonsense. 52-year-old male, last eye exam about 2 years ago, no dilation. He noticed a peripheral blind spot in his left eye more so than his right, mostly when he's driving. Look, he has trouble with the side view mirror. No change in visual acuity, no daily activity challenges other than driving. Glasses don't seem to improve his blind spot. He's 20/20 each eye, no afferent defect, examination normal cup to disc ratio, normal looking optic nerves. was seen by one of my colleagues in our practice in another office, and she did a visual field screener like this. And this came back, and she said, Joe, I'm not comfortable with this. Do you mind taking over and helping out with this patient?" Which, of course, I'm glad to do. So we see his visual fields, and that brings me to a polling question. Is this a nightmare or nonsense?
Okay, I promise I have it open. And it says A, nightmare because he's nearly blind, nonsense because he is likely malingering.
Greg, I think you're working as hard tonight as I am. You're keeping up with the chat. You keep up. I got all these polling questions going.
And I just helped someone that got knocked off for some reason get back on. So I think
So what does
we
our
are.
audience think here?
I'm just checking the chat. We're caught up there since you mentioned it. Let's see, where are we with this one? All right, I think we have a good amount. Let me display it. We have 55, nightmare because he's nearly blind.
Well, what we do is, let's do a formal visual field. And what do we see here? If you look at just the pattern deviation, total deviation, it's not helpful. Look at the blind spot. We can see he's got a left homonymous hemiopic defect. He, of course, needs neuroimaging. And he had a large mass. Differentials include macroadenoma with infarct, craniopharyngioma. He has some mild hydrocephalus. He ultimately wanted to run a craniotomy with near complete removal of the tumor. He was lost to follow-up, but his wife called twice and left a message thanking me for finding her husband's brain tumor. Now, nightmare or nonsense, I think for the sake of time, we're not going to do any more polling questions, Greg. But this is a 68-year-old male who had cataract surgery. Has capsular haze, undergoes YAG, and comes up 2025, and says, "My vision is worse now than before my surgery. Bright lights bother me. I'm missing letters when I read." Now, I clipped this right out. It's all caps, so I assume he was yelling at the tech. He feels his surgery was botched. His exam was normal. He was co-managed by one of our in-house optometrists. They couldn't find an answer. They referred to our retinal specialist. He found a few little retinal hickeys that didn't explain anything. Said possibly he had an old ischemic neuropathy. Let's do a neuro referral, which the neuro referral he referred to me for a neuro workup. And we do the visual field. And what do we see there? He has got a right homonymous hemiopic defect. Please get away from just looking at the total and pattern deviation for neuro-op. Look here. Look at the grayscale. It shows you the neurogenicity. And of course, he did have a mass. It looked like it was probably a supracellular arachnoid cyst, but it was very large. It was causing 4 millimeter midline shift. At 5 millimeters, the risk of a seizure and death goes up. So it's really a nightmare. And it was actually very hard for me to get a neurosurgeon who would tackle this tumor. He's a 33-year-old male who has occipital headaches for about 4 months, visual or with his headache. Worsen when he stands after sitting, so posture changes affects his vision, his headache. It's relieved by sleep. He has no vision loss, no nausea, no double vision, no pain eye movements, no behavioral changes. He had undergone an age-appropriate physical examination, and his internist did what a lot of internists will do when a patient has headache, says, "Go get your eyes checked." So he gets checked. He's 20/20 in each eye, myopic correction, nothing unusual. Pupils, EOMs, confrontation fields, biomicroscopy, nerves were fine, slightly nasally inserted, 0.3 CD ratio, and there is his visual field. And one may feel pretty good about this, and the patient has a clean visual field, and that we feel we're kind of out of the woods here. But remember, he had headache. He had a posturally changing headache. When he stood up from sitting down, his headache got worse. So this is where we lower the threshold and get neuroimaging. And this was a nightmare because he had a large mass. Now, this is not the patient. This is just a representative example. So he had a very, very large brain tumor. Ultimately, he underwent craniotomy and 2 rounds of chemotherapy. He did very well. He was a dental student at Nova at the time, and he went back to dental school and he graduated and went into practice. But unfortunately, he died from brain cancer 5 years later. So, a normal visual field doesn't mean there isn't anything wrong. It just means the visual system has not been impacted. Don't rely upon that. Now, this is a 39-year-old male who's got a previous history of migraine, who developed lethargy and a new and worsening headache. He went to a hospital emergency room where he underwent a non-contrast enhanced CT and MRI, both non-contrast, of the head, which were both interpreted as being normal. So his headache was attributed to migraine, although he was already a migrainer, and he was given a new medicine for migraine and discharged. Now, 3 days later, he develops horizontal and vertical double vision. And what we can see on this patient, he's got a partial ptosis in the right eye. He cannot abduct his eye, and he cannot adduct his eye. So it looks like we have involvement of 3 and 6. This has actually happened during COVID lockdown and was seen by one of my former residents as an emergency. And when he got into the weeds with the double vision, he gave me a call to ask for some help. So whenever I have a double vision or ophthalmoparetic patient, first thing I'm going to do is I told him, go back and film the motility and send me the video. So this is what happened. We got a partial ptosis. He doesn't adduct or abduct. All right, so I looked at this and I texted my former resident back and said, are you doing EOMs or are you playing with a cat toy? You're just like circling him around. So let's go back and just film me a physiologic H and just do it again. So he doesn't get some up and down and up and down. So he doesn't look up very well. He's got a partial ptosis. We see that he has an abduction deficit, all right? So he's got multiple cranial neuropathies here. Now, I also said go back and do a visual field, very important. His acuity is normal. His visual fields were full. So he has got a right pupil sparing partial third nerve palsy and a concurrent right sixth nerve palsy. Also complains of worsening headache and lethargy. So the question is, where is the lesion? Well, there are 2 places that this can be where 3 and 6 come together. They both come together in the cavernous sinus, and they both come together in the posterior orbit. But also in the posterior orbit is the cranial nerve 2, and vision is good. So I am thinking probably cavernous sinus. Let's contact that radiologist for a second reading. And we tell him to look specifically at the cavernous sinus. And he looks, and his response was, no, cavernous sinus is absolutely fine, but the pituitary gland looks a little bit chubby, was his words. And at that point, I knew what we're dealing with. We got to get the patient back into the hospital. He is sent back to an ER for repeat imaging, contrast enhanced MRI of the paracellular area, and an MRI to rule out intracavernous aneurysm. I'm looking for pituitary apoplexy. His imaging now has a pituitary macroadenoma that has bled and expanded like a blood balloon. It spread into the right cavernous sinus, is beginning to spread into the left cavernous sinus, but it was not moving superiorly and was not affecting the optic chiasm or prechiasmal portion of the optic nerve. That's why his acuity and his fields were actually all normal. So he is immediately admitted for endocrinological and neurosurgical evaluation. So apoplexy, pituitary apoplexy, is another true emergency because these patients can die. It is a potentially fatal medical condition affecting about 10% of all pituitary tumors. And keep in mind, they may not know they have an adenoma. Variable association, headache, vomiting, visual impairment, ophthalmoparesis, altered mental state, altered consciousness, lethargy because they have panhypopituitarism. Now, this hemodynamic instability, occurs when there's no adrenocorticotropic hormone, and this can be fatal. They can die from this. And the headache comes from a rapid expansion, usually hemorrhagic or infarction of a pre-existing, though sometimes unknown, pituitary adenoma. You can get a third nerve palsy, fourth nerve palsy, sixth nerve palsy, and very common is a bitemporal defect that happens very suddenly. Now, positive outcome in most cases. They can be treated. They can be treated with medicines, hormones, and ultimately surgery. Now, this is often overlooked in the ER as a potential cause of the severe thunderclap headache. People don't really think about this. When a patient comes in with a severe headache, they're going to be looking for intracranial hemorrhage, subarachnoid hemorrhage. They're going to be looking for cervical artery dissection, carotid dissection, vertebral artery dissection. They don't think about pituitaries. They don't think about pituitary adenoma. So, or they don't think about pituitary apoplexy. Now, if it is hemorrhagic, a non-contrast enhanced CT may pick it up, but generally you need an MRI with contrast directed to the sellar and parasellar areas in order to pick something like this up. So very important to have the images directed. Now, this is a person who had been worked up in the hospital for 3 days, had a CT and had an MRI. Both were non-contrast and neither were directed. They weren't looking for anything direct. So that could explain why this was missed. Also, could explain that it was developing. That by that 3 days after admission, it expanded so much it was invading the cavernous sinus. Sometimes they'll go laterally into the cavernous sinus. You get ophthalmoparesis. A lot of times it'll go superiorly and touch the chiasm, giving you a new onset bitemporal defect. So new onset bitemporal defect, severe headache, bing, you've got pituitary apoplexy. Potentially very fatal. Now, they can have a positive outcome. In many cases, they will. They undergo a conservative medical treatment, hormone replacement. They can be stabilized. If they have neuro-ophthalmic findings, vision loss, visual field loss, ophthalmoparesis, ultimately they're going to need surgical decompression. Use a transsphenoidal or transfrontal transcranial approach. These are people, if they have neuro-ophthalmic findings, they're going to need to have the tumor and the blood all removed. Now, this was during the COVID lockdown, so nobody really wanted to do anything that was unnecessary. So he was medically stabilized by endocrinology. They replaced his hormones. They delayed the surgery until COVID lockdown had been lifted. Once it had been lifted, he underwent a successful surgical decompression. To the best of my knowledge, he is doing very well today. Now, here's our resource slide, some things to remember. Full field 120-point screenings are not helpful. I don't ever use them. They're just non-directional. The first case that I showed you, it led us nowhere. I mean, it missed almost all the points. All right, 30. All right, threshold perimetry is what we need to do. 30-2 is not really better than a 24-2. I mean, I see people who are examining a patient with headache. They order a 30-2. The extra points are not going to be helpful. A 24-2 is more than enough. You don't need to see the standard program. You're not looking for an early glaucomatous scotoma. A fast or faster program is acceptable because neuro-op is not subtle. All right, 24 forget the 120-point screening, not helpful. 30-2. Not any better than 24-2, and just use a faster program, and look at the bloody grayscale. That will show you the neurogenicity. That is incredibly important. All right, so that's what we need to look at is the grayscale. Now, I just showed you 4 mass lesions. I'm going to summarize them. These are 4 mass lesions of patients that I've seen. Each case, vision was normal. 2 cases had vertical field loss. 2 cases had normal fields. Headache was present in 2 patients. 2 patients didn't have any headache. There's double vision ophthalmoparesis in 1 case. Yep, 3 cases didn't have double vision. No patient had any disc pallor, and no patient had papilledema. So the conclusion here is mass lesions don't always follow these expected rules. So, Greg, I think that's about it. We're right at about our time. I'm glad we were able to pull this off. It was a little bit touch and go with my internet and having to relocate to get this done. Is there anything in the chat room that I need to address?
There is nothing in the chat box that you have to address.
Excellent. Well, hopefully everybody enjoyed and got something out of this. I'm going to stop sharing, Greg, and let you take on over.
Fantastic. So with that, before we end it, you should see, because I see it, right at the survey, there's a little red dot. I'll highlight it for you. If you click that, you can start the survey, or you can wait until 10 more minutes and you'll get the email with it. So Joe, all your questions have been answered. If you click on your chat box, you're starting to get your virtual round of applause. Thank you. Thank you. Questions have been answered. Thank you, Joe, for doing this. Obviously, you make it simple, make it nice, stay calm, give us some great pearls. Obviously, you do it every day, and it helps us to help us do it whenever it comes in. This was Navigating Neuro-Op, Nightmares and Nonsense. This was a synchronous virtual course. Thanks, Joe.